My name is Will Harris. I'm one of the vascular surgeons at Vascular Institute, and I've been in the practice full-time since 2020, so thanks for everybody attending. We're going to talk about aneurysmal disease. I have nothing to disclose. I always like to start these presentations on aneurysms. For those who've been here before, they don't spoil it for everybody else, but talking about one person in particular, in 1948, a 69-year-old gentleman presented with a bulging mass in his abdomen, and he was subsequently taken to the operating room by one of the more famous general surgeons, but we'll reveal that gentleman in a little bit. Why is aneurysmal disease so important, and why do we care so much? It's present in 8% of males up to age greater than the age of 65. It's one of the highest causes of sudden death in the United States in elderly gentlemen, and so it goes underdiagnosed. It's underappreciated. Several causes, many people who die of sudden death actually die of a ruptured aortic aneurysm. And for patients who are have an aneurysm greater than 5 centimeters, the 5-year rate of rupture and subsequent death is upwards of 40%. And when they rupture, the patients more often than not die. 75% of patients die before ever even reaching the hospital. And of those 25% that actually reach the hospital, 50% die before they actually get on the operating room table. And those who actually make it to the operating room table, there's only about 7.5% are anatomically feasible to undergo endovascular aortic aneurysm repair. That number is probably increasing a little bit, but still the rate of mortality is upwards of 80% to 90% for ruptured abdominal aortic aneurysm. So brief anatomy, when we're talking about abdominal aortic aneurysms, we're talking about below the diaphragm. We've expanded this to treating aneurysms in an endovascular fashion all the way up into the ascending arch with tricks and techniques and things like that, and even around the visceral segments, around the renal arteries and around the mesenteric arteries. And when we talk about aneurysmal disease, we talk about a normal aneurysm, a normal aortic diameter being around 2 centimeters in maximal diameter. We don't usually treat them until they're around 5 to 5.5 centimeters, and we'll talk about that in a minute. Who do we look for with aneurysmal disease? Well, obviously age makes a difference. Male gender, we do see them more frequently in males. However, we treat females as well with regularity. Patients with high blood pressure, the typical suspects that you would typically see for peripheral arterial disease, high cholesterol, a history of smoking, obesity is a risk factor as well. Also, race plays a large part in it. We see it more often in African Americans and Asians, patients with diabetes, things like that. I'm sorry, race is a negative factor. We actually see it more often in Caucasians than we do in African Americans. But smoking is the greatest causative risk factor for abdominal aortic aneurysms, so much so that the Preventative Services Task Force and recommendations for abdominal aortic screening have looked at patients over a large cycle and recommend, and Medicare pays for, a one-time screening in those over the age of 65 who have ever had a history of smoking. So if you walk in and say, I've had a cigarette in my life, and you are over the age of 65, then we will, then Medicare will pay for an ultrasound screening of your abdominal aorta. And we've expanded this. The Society for Vascular Surgery, in conjunction with the American College of Cardiology, released guidelines, fairly broad-ranging guidelines in 2018 that looked at both men and women who have a history of tobacco use and recommend a one-time ultrasound to screen for abdominal aortic aneurysm. So it's a non-invasive test. It doesn't require any radiation. It's a fairly quick test, and it's fairly sensitive. So and again, Medicare guidelines allow for males with that family history. So this is an ultrasound view of an abdominal aortic aneurysm on the left. The sensitivity and specificity approaches upwards of 100%. And typically, if we see this on an ultrasound, then we'll get some sort of confirmatory imaging, like a CT abdomen and pelvis, to better characterize it and give us a better idea of anatomy. Most common clinical presentation, especially in the setting of a rupture is abdominal or flank plane. Pulsatile abdominal mass, that thing you see when you're laying on your back, it's not an alien in your body. And sometimes we just pick them up on screening exams, or oftentimes we see them on workup for, say, spine disease. Somebody gets an MRI and actually sees an aneurysm. So who do we fix? Typically greater than 5 centimeters. There's no real survival benefit in patients less than 5 centimeters who are asymptomatic. That being said, if a patient has a tender aneurysm on physical exam, then we will often speed up their care. We do fairly intensive screening prior to undergoing surgical intervention. However, if they do meet emergent criteria, then we speed things up if we have to. Perioperative management can include statin therapy. It's actually been shown to reduce mortality in elective aneurysm repairs in patients who are on a statin therapy. So we insist on that. We also insist on, aspirin, strict blood pressure control, diabetes control, things like that. So that patient that I was talking about underwent surgery in December 1948 at Brooklyn Jewish Hospital. The only treatment at that time was they actually opened up his abdomen and wrapped his aneurysm with cellophane. And that created a fibrotic state of the aneurysm and actually prevented it from growing any bigger for several years. That was Albert Einstein. Lived another 5 years until it ruptured again. He knew exactly what it was when it ruptured, and they offered him another operation, and he said, I'm done. He'd done his bit for king and country in the world. So, first replacement with a homograph, like essentially cutting out the aneurysm and replacing it, was in 1952. We've moved on since then. But we still do some open repairs. And it's sort of described by these pictures here. Essentially, you replace the aorta with a graft. That graft is made of a woven material called Dacron. But in 1990, we moved into the future in Buenos Aires, of all places, where somebody stuck a graft on a stick, essentially, and put it in, delivered it through the femoral arteries. And what you do with an endovascular aortic aneurysm repair is you exclude all the blood flow from hitting the aneurysm walls by putting in a large stent, where all the blood flow hits the stent and takes all the pressure off the wall of the aneurysm. So we do these in hybrid operating rooms. On the left, you can see the fixed fluoroscopic imaging. These take anywhere from 45 minutes to several hours. We access in the common femoral arteries, we do an aortogram, and then we run a catheter or a stent graft up into the abdomen. There are multiple grafts on the market. All of them are somewhat similar in nature. They're all made of a material, either Gore-Tex or Dacron, and they're impermeable to blood and take all the pressure off the walls of the aortas. You see up top on this picture here, what we try and do is land the stent graft just below the kidney arteries. This one, the aneurysm actually extends all the way up to the kidney arteries. You can see the left kidney artery up here. The graft is stuck on that delivery device, which runs over a wire up into the aorta. And then we deploy it, and all the blood flow goes into the stent graft and takes the pressure off the wall of the aneurysm. The strut's actually extending up higher above those kidney arteries there. It's what's called suprarenal fixation. It just gives you an extra measure of support of the graft. Grafts have evolved over the years. They adopt to more challenging anatomy. You can see how tortuous these iliac arteries are. We size the aortas with cross-sectional CT scans in order to give us a better idea of what size grafts to put in. Not every patient is the same, and so we custom essentially we put together different size pieces of grafts in the abdomen to accommodate each patient. This is a 6 centimeter aneurysm we fixed a couple months ago. You can see it's got a fairly long neck, and when we talk about neck, we talk about that distance between the kidney arteries and the beginning of unhealthy artery or the aneurysm. And this is where we actually delivered it right below the kidney arteries. And that's just another picture of that aneurysm. This is one where we actually delivered an aneurysm, and just to get a longer term seal, you can see little drill bits that you can see right below the kidney arteries. I wish I had a laser pointer on this. And that essentially recreates an open repair. What those drill bits do is actually drill in through the graft and into the wall of the artery to give a more secure fixation. And then also we drill holes into the artery walls sometimes and deliver stents into the arteries such as the kidney arteries and the mesenteric vessels in order to preserve blood flow and extend and treat aneurysms that go up higher into the abdomen. Those are called fenestrated endografts. So here's a patient in 2011, way back, that we treated, had an incidentally noticed 4 centimeter aneurysm with a 2.63 common iliac aneurysm. Oftentimes we'll see abdominal aortic aneurysms mixed with iliac artery aneurysms. But in less than 6 months, the aneurysm had grown by over a half a centimeter. And so that suggested that we needed to fix it. It was a fast-growing, dangerous aneurysm. That's a cross-sectional CT. These are the iliac arteries. You can see how dilated they are, and they should be much smaller than that, about a centimeter in diameter. These were 2.5 centimeters in diameter, 2.6 centimeters in diameter. So we deliver the endograft proximally and then deliver the limbs. So each limb supplies each iliac artery, thus excluding the aneurysm. Pretty straightforward. Why do we fix these? Which patients are we looking for? Those with high risks of rupture are those greater than 5.5 centimeters, currently smoking, those with significantly elevated blood pressure. Female gender has an increased predisposition to rupture. And severe COPD. We'll actually fix patients with severe COPD at 5 centimeters and have a low threshold to fix it even a little bit lower sometimes. Risk of rupture goes upwards of 11% greater than 5 centimeters per year. And at 6 months, at over 6 centimeters, the risk of rupture per year estimates are up to upwards of 22% per year risk of rupture. So when we see those pretty large aneurysms, we fix them as fast as possible. The rupture happens because of a loss or weakening in the wall. And like we said, that's usually typically associated with aneurysm size, although we've all seen aneurysms that have ruptured at 4.5 centimeters. When an emergency room physician sees a suspected rupture, severe abdominal plane flank pain, sends them the CAT scanner, gets confirmation, alert call team. We have dedicated vascular teams that come in, drive in from their homes, and we get them in the operating room as fast as possible. We look at the CAT scan, determine if they're an open candidate or an endovascular candidate, and really we move as fast as possible. You've heard of the door-to revascularization time for cardiac of 90 minutes. Well, we try for the same thing with abdominal aortic aneurysms. Sometimes we'll have to fix these with an open tube graft. The perioperative mortality increases with increasing comorbidities. So age greater than 76, systolic blood pressure on presentation is very low, presenting acidosis, or a serum creatinine of greater than 2.0 all confers increasing risks of mortality. Open repair definitely has more complications and is more morbid a procedure than in a ruptured setting. If we can do it in an endovascular fashion, in an endovascular room such as this, the patient stands probably a better chance in the 21st century. This was a ruptured abdominal aortic aneurysm from, I can't remember when this was. I've got one, actually this is a better one. This was last year, presented to an outside emergency room with flank pain, transferred emergently. You can see the aneurysm is on the left, the rupture is on the, or I'm sorry, the aneurysm is on the left side of the screen. The rupture is on the right side of the screen, which is the patient's anatomic left side. So that big collection of blood off to the left is a bad sign. So they were taken emergently. We did it percutaneously and delivered the stent graft up into the aorta. But unfortunately, the patient was already way behind the power curve when we were able to get to him and subsequently succumbed to his disease. So this is why we do it all. So thanks, y'all. Appreciate it.
My name is Jenny Wilson. I'm a nurse practitioner at the Vascular Institute. I'm going to be talking about renal vascular disease. Now I have no disclosures. What is renal vascular disease? It is a group of disorders that affect the blood flow in and out of the kidneys. It can cause kidney damage and lead to kidney failure, and also cause hypertension. There are many conditions included in this category of disease. Renal artery stenosis, which can be caused by atherosclerosis and fibromuscular dysplasia, renal artery thrombosis, renal vein thrombosis, renal artery aneurysm, and then atheroembolic renal disease. For this presentation, I'm going to focus on renal artery stenosis caused by atherosclerosis and fibromuscular dysplasia. Renal artery stenosis causes 90% of renovascular hypertension and is the most common cause of secondary hypertension. Risk factors for renal artery stenosis include atherosclerosis, other places in the body, high blood pressure, high cholesterol, diabetes, current or history of smoking, advanced age, and then gender plays a role depending on if you're discussing atherosclerosis or fibromuscular dysplasia. Renal artery stenosis that is secondary to atherosclerosis is a formation of atherosclerotic plaque on the artery wall that causes your area of stenosis. It usually occurs at the aortic orifice. It's more commonly found in males and typically found in patients with other atherosclerotic disease, although it can occur as a single lesion. The chronic ischemia leads to secretion of renin and activation of the renin-angiotensin-aldosterone system, which leads to your hypertension. Fibromuscular dysplasia is segmental disease that is not caused by atherosclerosis, and it affects the musculature of the arterial wall. The dysplasia causes areas of stenosis, aneurysm, and dissection. It's most commonly found in the carotid and renal arteries, although it can affect any small or medium-sized arterial bed. It's more frequently found in women and is the most common cause of renal artery stenosis in young patients. And it typically involves the distal portion of the artery. When you're treating patients, when should you suspect renal artery stenosis? If you have a patient with an onset of hypertension before the age of 30, or a new onset of hypertension in a patient that's older than 55, you should be considering this. Or if your patient has accelerating hypertension or hypertension that is resistant to medication, or a patient with progressive renal failure that has a normal urinary sedimentation rate, or in patients that just have signs of atherosclerotic disease. What we use for diagnosis, combination of ultrasound testing, CTA, MRA, and then angiogram. What we use most commonly in our practice is ultrasound. And ultrasound looks at a few different things, including the peak systolic velocity, so measuring the speed that that blood is moving through the renal artery. An elevated velocity indicates an area of stenosis. Your renal aortic ratio is comparing the peak systolic velocity in the renal artery to the aorta. And resistive indices, which are an indicator of vascular compliance. In a healthy kidney, it should be less than 0.7, and an elevated finding suggests intrinsic kidney disease. So this helps us to determine if that resistive indice is abnormal. It can kind of help us pinpoint if their hypertension is related to a stenosis or some other kind of renal disease. And then also looking at kidney size. So we're measuring the kidney to see is it in a normal size range for a male or a female, and then also comparing the right and the left kidney. This is an example of an ultrasound from our practice, and you can see that you've got elevated velocities at that origin and the proximal renal artery, which indicates that this is related to atherosclerosis. You also have an elevated renal and aortic ratio, but our resistive indices are normal, and the kidney size is relatively normal. And then examples of ultrasound imaging. And that second picture, it is showing the fibromuscular dysplasia, which you can see the segmental disease, and it is classically called a string of beads, where you have the areas of dilation and then the stenosis. CTA, MRA also will identify renal artery stenosis. We get a lot of referrals patients with renal artery stenosis that it's an incidental finding. They were having abdominal imaging for some other reason, and this is identified, and then they're sent to us. And then diagnostic angiogram, that first picture, you can see that it's at the origin, indicates that this is more likely an atherosclerotic lesion. And then the other two pictures are more distal disease that show that fibromuscular dysplasia. That last picture gives you a really good picture of that string of beads look. Treatment options, so there's medical treatment, medications to lower blood pressure and control cholesterol, treating other comorbidities, including diabetes, and then lifestyle changes to reduce the risk factors, especially controlling or quitting smoking if patients are able to do that. And then vascular intervention is required sometimes when the medical treatment is not enough. And when we are looking at a patient and deciding if intervention is indicated, there's certain factors that have to be present. Number one, you've got to have a hemodynamically significant stenosis of greater than 60%. And then once you've established that, you also need one of these other situations. It can be a solitary kidney that has that stenosis, and we're going to be more aggressive in treating it at that point because we want to preserve that solitary kidney. Or if the patient has uncontrolled hypertension with the use of 3 or more antihypertensives, then we're going to consider treatment. Or a patient has a decline in renal function with an unstable GFR, then we're also going to see that as a sign that maybe it's time to do some intervention. The options that we have for intervention, most frequently we treat this with an endovascular approach using angioplasty and stenting. There are open surgical options for patients who are not a candidate for endovascular repair. Treating renal artery stenosis requires a team approach. We don't necessarily find these patients on our own. They are sent to us by nephrology, by primary care, and then we all work together in treating this, managing it, and deciding when intervention is necessary. So primary care helps to identify patients that are at risk, manage the other hypertension, hyperlipidemia, and the comorbidities. And then a lot of times primary care is referring to nephrology when there's decreased renal function, and then referring to us if there is high suspicion for the stenosis or an incidental finding of it on imaging. Nephrology is also identifying patients. We get a lot of referrals from them, and then managing chronic kidney disease. And we work with nephrology and getting clearance for treating these patients. If you've got patients with severe renal disease that have a really high creatinine, we're trying to make a decision, are we going to do more harm than good if we're using dye and doing an angiogram? And nephrology works with us a lot and saying, okay, yep, we're okay now, you can do this. And then helping us to know when we need to do something. They're identifying that change in renal function for us. If they're monitoring a patient, then they can give us a heads up and say, hey, we've had a change, we think there's a problem here, and let us look at it. And then as vascular surgery, we're making the diagnosis, monitoring for progression of disease, and determining when indication or intervention is indicated. And then referring patients back to primary care a lot of times for that blood pressure management, because we don't treat these patients typically unless they have uncontrolled blood pressure on 3 or more antihypertensives. So sometimes we will identify that, yes, there is a stenosis here, but this patient's only on 1 or 2 medications, and so we're going to send back to primary care and say, let's try optimal medication management and see if this blood pressure comes down. If it does, okay, we don't need to do anything. If it doesn't, then we're going to consider intervention. And then if we get a patient that has renal artery stenosis that is not already established with nephrology, then we'll make that referral to nephrology, again, just to have that team work to monitor their renal disease and help us to do our job better. So takeaways, if you have suspicion for renal artery stenosis, please send them our way. The outcome of untreated renal artery stenosis can be occlusion of that renal artery, and the patient loses their kidney. So we would much rather see these patients and say, nope, this isn't your problem, than get them and have to tell them that that artery is occluded and they've already lost that kidney. And then again, team approach. We all need to work together to treat and manage these patients. And that's it.
All right. Well, thank you very much. My name is Matt Wiisanen. I'm one of the cardiologists over at Centennial Heart at Park Ridge, and I want to just take a second to, first of all, thank the Vascular Institute folks, specifically Tracy and Chris LeSar, for putting this together. This is a really remarkable conference for Chattanooga, and to be able to bring something like this to the community, I think is phenomenal. So a quick round of applause for our hosts here. Thank you very, very much. And I've promised that I would stay on time because I've been historically known for not. So I'm going to make sure that I'm staying on time today. All right, so I've been asked today to talk about cardioembolic phenomenon and complications in the arterial space. So my background is not only that of being a cardiologist and an interventional cardiologist, but I really focus on the structural aspects of the heart, and specifically structural abnormalities in the heart that can be treated via percutaneous options to try to help patients with their conditions. No significant disclosures today that are going to come up in this talk, but what we're going to do is try to better understand what actually makes up cardioembolic disease and what its impact is on our patients, and then what workups we might think about or consider when trying to better treat and understand these patients, and then look at our treatment options. So the typical scenario that I get from this is I'll get a phone call perhaps from Dr. LeSar, and he'll say, hey Matt, I've just taken care of a patient who had an embolism into their right leg. We cleared it out, we opened things up, and things are good, but where did this come from? What happened that caused this? It wasn't atherosclerotic disease. It must be a clot from somewhere. Is it coming from the heart? And so that's what we have to try to figure out. So really, embolism is just the occlusion of a vessel by a foreign object. And cardio is cardio. So we're going to sort of dive into that a little bit, and first of all, figure out what types of emboli are we dealing with? Are they all clots, or could they be other things? So one of the more common ones that we see is infection. So we see infection of valves, something that we refer to as endocarditis, that can really plague patients with distal embolic phenomenon. So for instance, we have patients who will come in who may have peripheral embolic disease. You see it on their fingers and toes on exams. There'll be purple and painful lesions, typically under the nails or in the fingertips in particular. And then what we also see is a common spot is the brain. So we do CT imaging, MRI imaging, and we can see that some of these emboli will make their way, unfortunately, up into the brain and can cause strokes. Atheroma and calcium are other problems that can arise from cardiac sources, particularly valves. And as somebody who does a lot of work on aortic stenosis, mitral valve disease, and the like, we can see that these problems can arise on valves and then break loose and cause problems in the periphery. And then when patients are in the hospital, and if they're getting either a procedure done or they're getting an IV and they happen to have a patent foramen ovale, they can oftentimes, or not oftentimes, but not infrequently have problems with air emboli. And so this is, again, something that we see from time to time that can traverse the heart and implicates the heart for various treatment options down the road. The sources within the heart are many. So the most common that we think about is the left atrial appendage. So the left atrial appendage is this remnant embryologic tissue from heart development that is there. You can think of it as the appendix of the heart, but we know that 92% of all emboli from atrial fibrillation arise in the left atrial appendage. And so that's the focus of our treatment when we put patients on anticoagulation for atrial fibrillation. So the left atrial appendage is a real hot spot for stagnation and thrombosis formation when patients have atrial arrhythmia. Valvular locations are a very common source, as we mentioned. And then arterial, too, especially in sort of the proximal and arch vessels, we can see atheroma lead to arterial thrombus formation and those kinds of things. So arterial is still part of all this. And then ventricular. So for a lot of our patients who have cardiac dysfunction, they have a low ejection fraction, they may be prone to having a left ventricular thrombus, and that could in and of itself be something that could embolize and cause problems on down the road as well. And then paradoxical, so meaning that we have probably a venous thromboembolic problem, and that they happen to also have a patent foraminal volley, which occurs in about 30% of the US population, and this little thrombus crossed over, instead of going into the lungs, crossed over the PFO and went into the arterial side to cause complications. So the targets for where these go can be the brain most commonly, since most of our cardiac output goes up to our brain. The most common spot for embolic disease is to the brain, but we can see it in the gut and the extremities. And so this can take all different locations for us to really hone in on. What's the prevalence? So here's where we don't really know the answer. We have some pretty good ideas about what the prevalence is for cardioembolic implications in stroke. But when we take a step further and we say, well, what about things that are going to the limbs? What about things that are going to the gut? We really don't have any good data to say what the prevalence of this is. But I'm here to tell you today that if you have an embolic phenomenon that went to your gut or your foot or your hand, that thankfully it didn't go up to your brain and cause a stroke. So this is really a stroke of your hand or of your gut. So we have to think of it in those terms. So again, the diagnostics are pretty straightforward. It's, H&Ps and then probably some brain imaging or some CT imaging, abdomen pelvis, blood cultures if we think this is endocarditis. And then echocardiogram is a really important mainstay of diagnosis within the cardiac space, and particularly transthoracic echo is a great place to start, but oftentimes if you're thinking about looking at the left atrial appendage, or you want to look at a PFO, or you want to look higher up in the atria, you'll oftentimes need a transesophageal echocardiogram. And then cardiac monitoring, I think, is not a well-stated need for a lot of these patients who may have some problem. And oftentimes, if they're younger patients, we may do a 1-month event monitor to see if they've got atrial fibrillation. And typically, it's not an event monitor, but it's more of the continuous monitoring with an MCOT. But then for some of our older patients, and I'm going to put myself in this category, you're 40, 50, 60, and upwards, we oftentimes have to think of longer monitoring, so more than just a month, because we know that patients can have an episode of atrial fibrillation, and many times silent, but they could have an episode of atrial fibrillation in a 4-month period, and that could still be a risk factor for throwing clot. So this is something we're monitoring long-term is important. Anticoagulation is really the mainstay of treatment for a lot of these problems, and this may be oral or parenteral. In the acute phase, many times we'll think about maybe even using fibrinolytic therapy, antibiotics if this is infectious disease related, endocarditis, and then talking about getting our vascular surgeons and folks involved for endovascular and open surgical repair if necessary. Now, the immediate cardiac treatment options are many, and we can go anywhere from just medical therapy with anticoagulation and fibrinolysis and antibiotics for endocarditis to the percutaneous options for treatment. So one of the things that we can do is we can use some of these larger catheters that you see out in the hallway to do either thrombectomies or what I lovingly refer to as the vegectomy, to take off these vegetations off of tricuspid valves or mitral valves or aortic valves. And then the surgical thrombectomy, debridements, repairs, all of those things are all part of the treatment strategy in the initial management. But long-term, we have other things that we need to think about. So we can talk about aspirin as a potential strategy, but aspirin's actually taken a little bit of hit in the media lately. You guys see this? Where maybe we aren't as hot on aspirin as we used to be, and maybe aspirin isn't for everybody, and it causes GI bleeding and stomach ulcers and kidney problems. And so you can see here that aspirin in the guidelines from the American College of Cardiology only gets a 2A recommendation for valvular heart disease. And really, there's not a whole lot of other room for aspirin within the guidelines. When we look at aspirin and atrial fibrillation from the early trials that were done, the SPAF trial that was done years ago, was really the one trial that showed where aspirin was beneficial in stroke prevention and atrial fibrillation patients, but now we've got all these great anticoagulants out there that have really surpassed aspirin alone. So in our higher risk patients, we're thinking about things beyond aspirin. So we talk about the DOACs, and we've got all of these trials that look at all of the great medical therapies, the great advances over the last 15 years now that have really shown that, DOACs compared to warfarin are at least non-inferior, if not superior, in some of their risks of preventing strokes or preventing bleeds and those kinds of things. So we use a lot of those. And when we get into vitamin K antagonists, the warfarin and such, we can see that some of this data is still very old, but there is a curve in which if you're subtherapeutic, you're going to be at an increased risk for thromboembolic events, and if you're too high up on your INR, you're at risk for bleeding. So finding your sweet spot with warfarin is sometimes a challenge. Now, I put this up here because when we talk about preventing problems in the arterial space, all of our data comes from venous thromboembolic disease. So we don't really have good recommendations when it comes to arterial disease. So you can see we use rivaroxaban or apixaban or dabigatran, and these meta-analyses suggest that there are really no differences in the venous thromboembolic recurrence rates and no difference in bleeding as compared to vitamin K antagonists. When you look at warfarin versus observation in DVTs, this dates back to the 1960s, but again, you have a significant reduction in the recurrence with a mortality benefit. Lipid lowering, as Dr. Harris mentioned earlier, is a very important strategy, and statins really play a big role, and PCSK9 inhibitors are really coming to the forefront in a lot of those as well. So more on that as we go along. PFO is certainly something that we think about and look for because of this paradoxical embolism. And so we had a number of trials that came out in 2017 suggesting a significant improvement in reducing the risk of stroke. But again, peripheral arterial embolism, we think, again, this is the stroke outside of the brain. So we have to go and think of it in those terms. And these are the conversations that I've had a number of times with Dr. LeSar, and this is the workup that we embark on. So again, in the eye, in the liver, in the spleen, in the kidneys, anytime you have embolic phenomenon, you have to think about where it may have come from. And in particular, this bottom slide, even in the heart, we can have emboli go into the coronary arteries and cause acute heart attacks like this. So we know that PFO closure is good at reducing these kinds of events. And then what we talk about when it comes to atrial fibrillation is really oral anticoagulation is really the mainstay for the higher risk patient, but now we're getting into a situation where, left atrial appendage, your Watchman and amulet procedures are really supplanting the use of anticoagulation in your higher risk patients who are at a high risk of complications from long-term anticoagulation. So we see that these are good options to implant the Watchman device in patients who need to have a reprieve from their anticoagulation because of bleeding risk. So in summary, cardioembolic disease can affect any organ arterial bed. Stroke is the most common and it's the best studied, but we have to think of these other things, these other phenomena outside of the brain as the stroke for those particular organs. A large number of pharmacologic treatments and options exist, but now we're increasingly seeing larger numbers of non-pharmacologic treatment options become available for the acute and chronic management. Now, what I've done in the slides here for this is that I have included some additional slides for some cases that I didn't want to go over my time today, but I'm always happy to talk about those and happy to answer questions. But I want to thank you for your time today and thank you for the opportunity.
All right, Matt, that was the fastest lecture you've ever given. And I thank you for it. We're trying to stay on time. At 12 o'clock, we do have a live case, so we're working on trying to work through some of the conference in a timely manner, and we're making it. So the next section is going to be me talking about mesenteric vascular issues. One of the things that we see at VIC we're big on saving limbs, but we also want to renew lives, so this is that renewing lives part of it. So when we have patients with PAD, we know that it's related to heart disease, lung cancer with a smoking connection, stroke for sure, development of aneurysm disease, and then on the bottom left side, claudication, rest pain, gangrene, embolization, the PAD things that we see very typically. But in the bottom right corner, we have ischemia, and ischemia to the kidneys or ischemia to the mesenteric vascular system, which is basically the intestines or the arteries that go to the intestines that allow us to absorb food and survive. So the number one cause of death in the United States in men and women is heart disease. The number 5th cause of death is stroke. It used to be number 3, so we're making progress. And the number one reason for amputation is advanced PAD. Also, very similarly, PAD causes the blockages that lead to acute mesenteric ischemia. And as a surgical house officer many, many years ago, we would deal with mesenteric ischemia in the operating room because it was too late. Pieces of the bowel have already were necrosed or dying, and we had to remove that bowel to save that person's life. So that was kind of my entry into dealing with mesenteric ischemia. Now, much of the time, the atherosclerotic disease affects 17% of patients over age 65, so it's the buildup of a calcification in the artery that leads to that intestine. And 40 to 50% of the patients presenting with acute intestinal infarction had prior symptoms. So they had postprandial abdominal pain, and they had different problems with digestion well before the fact that their intestine died and they ended up in an operating room. There's a rising incidence and prevalence of chronic mesenteric insufficiency in the U.S. population, as is most other vascular problems, and the optimal management of CMI requires early detection and revascularization, not waiting until the bowel actually dies. So the different regions that we deal with are the celiac artery, and you can see this artery comes off the main aorta right about where the xiphoid is, right in the midsection below the ribs. And that artery goes to the liver, the stomach, and the pancreas, and it's involved in early digestion. So when you put food in your stomach, it has to be dissolved by the enzymes from the pancreas and the liver, and the stomach has to macerate the food. And if that artery isn't functioning, people become full very quickly. They can't eat very well. They have pain when they eat. Or they start to have problems with diarrhea because of the lack of pancreatic enzymes. If it's in the superior mesenteric distribution, this is the region of the bowel that absorbs all of our nutrients and a lot of our fluid. And so if you don't have problems with there, you start to have a wasting disease. You start to lose weight, lose muscle. And so in the question I have for the audience is, which patient here has chronic mesenteric insufficiency? I don't understand why you're laughing. Both of these patients have chronic mesenteric insufficiency. And they'll present, in the first little lady, she is just slowly wasted away over years, loss of muscle, loss of connective tissue. Our other lady, which is more typical of your average Tennessean, has bouts of chronic disease, but also acute bouts. And so she'll present with acute insufficiency where we'd have to go back and repair something, and then she would be fine for a while, and then she would have problems again. So she also had chronic mesenteric insufficiency. So the hallmarks are abdominal pain after eating, usually delayed about 15 to 20 minutes, or there's increasing pain in frequency or severity of the pain. Changes in the type, amount, and frequency of food eaten. So they have smaller meals, they have it more frequently, or they start to reduce the amount of meals altogether and start losing significant amounts of weight. Early satiety, feeling full when you eat a few bites and they're full, and that can be a problem. Or 90% of patients have significant weight loss as a hallmark for this condition. And if you listen, take the time to listen, you'll hear an abdominal bruit. You can't miss it, 75% of patients. So 16% of patients do not have the classic symptoms. That's very typical. In all of our patients, they always present somewhat differently sometimes. Nausea, vomiting, diarrhea, or constipation can actually be the leading clue that you have. Now, if you have a problem with acute insufficiency, there's a classic triad, and we call it pain out of proportion to exam. They are in writhing pain or severe abdominal pain, but you put your hand on their belly and it's soft, and they're not complaining of tenderness when you push on them. They often have urgent kind of urgency with your vomiting or diarrhea, and they have a history of or a thought of a potential embolic source. Maybe they have atrial fibrillation in the past, but this is a surgical emergency in most cases. This is an example of a CT imaging looking at the body from the side. So you're looking through the body this way, and you can see that the arteries are coming forward. And so we see where the red arrows are, there are narrowings in the superior mesenteric artery. This person could be losing weight or having postprandial pain. This is an MRI example of a celiac artery narrowing, and also where the circle, the superior mesenteric artery, has a narrowing as well. And again, MRI can be used as a diagnostic tool to find this. Commonly intravascular or commonly ultrasound is our go-to. It's cheap, it's efficient, it tells me, is there a hemodynamically significant lesion? That's what I need to know to actually treat the patient. So we marry symptoms with a imaging study to actually decide what to do. This is when we take the patient to the angiogram suite and we perform angiography, looking at the various vessels. On the right panel, we can use intravascular ultrasound. It's basically ultrasound over a wire. It's about the size of a pencil lead. And I can slide that ultrasound over the wire and actually, like you're driving through a tunnel. So you're driving that wire through a tunnel. And you can see in the upper panel, the artery looks fairly normal, but the lower, there's a very tight lesion with a plaque that's built up. Now, operative management, or how we dealt with this originally, was a surgical issue. The first successful repair was in 1958. I'm not sure what people did before that, but they didn't do well. After the gold standard operations were started and figured out, we still had very high significant perioperative mortalities of 5 to 15% and 30% major morbidities. These patients are already ill, malnourished, and we're doing a major operation on them. And so that is what we tend to do only if we have to do it. Most of the management currently is through endovascular techniques where we can place a small stent. The lesions are located at the origin of the artery, and so technical success is very high in that 92 to 100% range. Mortality rates are very low, morbidity rates are very low. Reintervention rates are high, so people can have a repair and do fine for a number of years, and then they're coming back with symptoms again. They have to be back to be repaired. Now, there are some techniques with some of the covered stents that we have that actually have reduced that chance. So for management philosophy for most vascular surgery groups, it's an endovascular first approach. We do diagnostic therapeutic repairs. Open reconstruction is reserved for people with complex disease or a stent that's failed that you can't reopen, or some reason where you can't fix them with a balloon or a stent. Now, this is an 81-year-old female with postprandial abdominal pain and significant weight loss. You can see in the superior mesenteric artery that she has a 95% lesion where the arrows are. And in this panel, in the, the left lower, we did an angioplasty. And then we move up to the right upper, and that's where we have a stent on a balloon. And then we deploy that stent, which is in the right lower, where we complete the angiogram and actually open the artery with the stent. This is a 67-year-old patient with nausea, vomiting, early satiety, and she had a critical stenosis of that celiac artery, again about 95%, successfully treated with an angioplasty and stent. Now, the other artery that we really didn't talk about, which is the third mesenteric artery, because we don't usually have to fix this too often, is the inferior mesenteric artery. Occasionally, you can have a very large inferior mesenteric artery, and if we see that, that usually denotes the fact that that artery has an end organ, meaning that the left colon is supplied only by that artery. And when we see that, sometimes if we have GI bleeds in the left colon and a very large IMA, inferior mesenteric artery, we would actually have to repair that with a stent. And this is one of the few that I've had to do in a career of 20 years. So in conclusion, mesenteric insufficiency is postprandial abdominal pain, early satiety, weight loss. When you're doing your physical exams on people, you ask them about heart attack or stroke symptoms, loss of vision or motor problems or sensation problems. Do you have any chest pain? Are you having any pain when you eat? That is what you need to do. So, and then the last thing, are you having pain when you walk or weakness when you walk? Those are the main things that will cover most of the diagnostic part of the history and physical on your vascular patients. As far as workup, duplex ultrasound is cheap and effective, $300 for an ultrasound versus $3,000 for a CT and more for an MRI. First-line treatment is endovascular therapy with stenting of the affected vessels. Operative management is reserved for occluded stents, multivessel obstruction, and only in good surgical candidates. And I want to thank you for your attention. So I am a blind surgeon. I wear contacts, glasses for distance, glasses for up close. But my hands barely shake, so I actually do really good. So keep sending your patients to me. We're going to move forward with the PAD section now with Mrs. Stone. And I think unless there's any burning questions for Matt or myself, ask now or forever hold your peace. Yes, please.
Tell me, what is the life expectancy when you stent of those stents before they reach the nose?
Okay, so good question. So the question was, what's the life expectancy of the stent? So I've had patients that are decades out now with this, and the operative risk for the endovascular is, in my experience, way less than 1%. Versus an open case, open surgery, where you're at a minimum of 10% mortality rates. So the endovascular techniques have changed how we care for patients. So as a doctor, you want to do what's the least invasive, the least cost to the patient to get the best result. And what it means, though, is that I have to manage that patient long term. So, but they're vascular patients. So once they're my patients, they're my patients. They don't go away until I go away, or they go away. And that's just part of the management process for vascular disease. It's a good question, sir.
How long can you go out? Oh, I'm sorry.
So the question was, how long do we monitor patients for occult atrial fibrillation? So again, there's, really two types of patients with AFib, those who feel it and those who don't. And unfortunately, many times that we're diagnosing atrial fibrillation is in the hospital when that patient's presented with a stroke. That being said, when Chris sends a patient to me, or we've seen patients with stroke and we're working the cardiac aspect up, typically if they are younger patients, the likelihood of atrial fibrillation is relatively low. And so in my patients who are in their 20s and 30s, I'm typically just doing about a month's worth of monitoring on those folks, just because if they don't have anything within a month, their likelihood of having occult atrial fibrillation is likely very low. Once we start getting a little bit older, though, and our risk factors for hypertension and other things, sleep apnea and the like, increase our risk of atrial fibrillation, then the data says that we should probably monitor for a minimum of 4 months. Now, oftentimes when we're putting loop recorders in, those are usually good for monitoring up to about 2 years. So those are patients for whom I'm going to monitor them for as long as that device is in. And we're typically not taking those loop recorders out, or very rarely taking them out. So you've already gotten the device in, you paid for it, you might as well monitor them for that period of time. But typically within that 4 months, if they haven't had anything, then I feel pretty comfortable in saying it's likely not the cause of their problem.
Just as an add-on, so if you implant a loop recorder and you say you could leave it in indefinitely, do you have battery change problems?
So the batteries on most loop recorders will last for about 2 years. And so once we've gotten to that 2-year mark, then it's usually done. And now some patients will want that loop recorder out, and so it's a little bit of a surgical procedure to take it out. But by and large, it's so small, and patients really don't pay attention to that it's even there or bothersome. And so it's oftentimes just left in after the battery's died at that 2-year mark.
Thank you.